Welcome to the Fundamentals of Sports Medicine Cervical Spine Lecture 101. Today's lecture was created by and large by our contributor and partner, Adam McCawy, who's on the call tonight as well. However, it's going to be presented by Ken and myself tonight. We're going to go through the anatomy, physical exam, and basics of X-ray interpretation for cervical spine. And of course, as usual, Fundamentals of Sports Medicine has no disclosures, financial or otherwise, to disclose at this time. If you haven't already followed us on our social media accounts, please do it. Twitter, Instagram, Facebook are all good ways of getting at us. And if you're not on the email list for some reason, email us at fundamentalsofsm@gmail.com. Just as an aside, for those of you who are currently in the interview season, we recently recorded a lecture on questions that we thought were relevant to ask for fellowship interviews, particularly in the season of COVID, and we've posted that to YouTube under our channel. So if anybody wants a link to that, I think we can link it during the episode at some point today. But otherwise, we'll get into our cervical anatomy. So I think something that I want to acknowledge to everybody is that cervical anatomy is something that I think people allow their knowledge of to wane somewhat after anatomy lab in medical school, unless you're in an osteopathic program. It's something that I don't think you consider very often. And so in light of that, I have tried to be somewhat methodical about the slides in this and to cover the basics of cervical spinal anatomy in a way that I feel is relevant and digestible for somebody who's planning on being a clinician more than an anatomist. To start with, of course, we need a basis for understanding it, and this is just some verbiage just so that everybody can help to orient themselves within the cervical spine. Keep in mind there are 7 cervical vertebrae with 8 cervical nerves. And just as a refresher, the cervical nerve the cervical nerves exit above the number of their similarly named vertebrae. In other words, the C3 nerve root exits above the C3 vertebra, below the C2 vertebra. Typically, the spine is also divided into 2 segments, the upper and lower. C1 and C2, or the atlas and axis, are the upper segment. C3 through T1 is the lower segment. Looking at the upper anatomy, this is an area that I'm really going to linger on, and then more actually of the anatomy after this is going to be somewhat easier to understand, but or let's say more similar to how the rest of the vertebrae interact. But lingering on C1 and C2 and the way that they articulate with one another can help to understand, first of all, the motion of the neck, as well as the basis for a lot of pathology that you're going to see in practice, potentially, hopefully not, but potentially, as well as what you're going to see on your board exams with regards to questions that they like to test about. So what we can see here on these 2 images on the left are the superior views, or the axial views, of both C1 and C2. And they're oriented such that the upper part of the bone is the anterior aspect and the bottom part is the posterior aspect. Now, the atlas has some interesting anatomical features which will contribute to some of the pathology that you're going to end up seeing with this, and stuff that we'll discuss at different points either in the lecture tonight or in a couple of weeks when we record a lecture more on pathology of this. First of all, one major component that I like to always point out about C1 is that it doesn't have a vertebral body. You don't have this major column on the anterior portion of the vertebra that you see on C2 and actually all of the other vertebrae. And in place of that, what you see is the odontoid process, or the dens of C2, projecting superiorly up into the anterior space. And while the odontoid process does not actually take the place of the C1 body, it occupies the same space that you might otherwise see it. But understanding how the odontoid process articulates and sits in this anterior space of the atlas is extremely relevant. Now, before we move on, let's talk a little bit about just the anatomy of what we're seeing here. So when we see, first of all, the superior articular facets, these are the articulation points for the skull itself, for the base of the skull. And of course, the atlas has two arches, the anterior and posterior arches, both of which are areas of some pathology, but which we won't get into tremendously tonight. And then the transverse foramen is the other aspect that you like to see. And those are going to be the sites of the vertebral arteries as they course superiorly through the spine and finally conjoined to become the basilar artery of the skull. Now, an area that you're going to see an enormous amount of pathology, at least on the boards. I'll admit I haven't seen a lot of pathology of this myself personally, but which I just kind of know from studying all of this material extensively, is with the transverse ligament of the atlas. And if you look, what you should be able to recognize or see is that this transverse ligament is connecting the anterior part of the atlas to itself. And what that does is it creates a sort of mesh or a cage around which the odontoid process sits. And the relationship of the transverse process to the odontoid process or to the dens is a basis for a lot of pathology, or at least a basis for measuring a lot of pathology. And this distance between the transverse ligament and the odontoid process has some known values above which you begin to suspect various fractures or dislocations actually of this process. The odontoid process can also fracture at times off of C2, which has its own range of pathology. But one thing I'll note also just about the spinal canal of both C1 and C2 is that they're extremely large. C1 is quite big as you take in the distal part of the brain, and C2 is actually the largest spinal canal of any of the vertebrae in the body. And so while pathology can certainly occur after a fracture of C2, it tends to have enough room that expansion of the spinal cord does not necessarily lead to compression of the spinal cord, which is just an interesting thing to be able to understand. I think the image on the top right gives us the best in situ view of what's going on. And just to orient people again, we see C1, or the atlas, sitting on top of the axis. And we have the odontoid process projecting superiorly again on the anterior aspect of these two vertebrae. And we see the transverse ligament wrapped behind the odontoid process there. This structure, which I didn't mention before, but this structure allows the rotational movement for the most part of the cervical spine. Ken, is there more that you'd like to add, by the way, about the upper bony anatomy?
Yeah, so just like Max said, that there's no body in C1. There are anterior and posterior arch. Also not a spinous process in C1 as well. I want to point out here that the facets here, the articular facets, also known as lateral masses or articular masses or articular pillars. There's many names for them, so just be comfortable with the names of them. So just in general, lateral masses. So lateral mass, lateral mass, lateral mass, and lateral mass here.
I guess maybe it's also a relevant point to mention the pedicles, if you wouldn't mind pointing those out as well. There are a couple of classical fracture types that you'll see in both the C1 and C2. Probably the most famous C1 fracture is the burst fracture or the Jefferson's fracture. And if you can imagine an axial force being directed downward through C1 onto the lateral masses or the superior articular facets or lateral pillars, what you'll see is that the ring structure itself of C1 can split. And this is a burst fracture that can sometimes occur, or at least it's caused from axial compression downward through C1. C2, on the other hand, more often we'll see a hangman's fracture caused from forceful hyperextension of the neck, where the odontoid process is often fractured. Although there was a study actually that was done, we can move on to the next slide, by the way, while I tell this very brief anecdote. There was a study that was done in 1992 where they looked at hanging victims actually to determine the rate of hangman's fractures in hanged victims. And it's actually quite low, interestingly, despite that being the uh, procedure, we'll say, in a sort of morbid way from which it gets its name. Moving on to the lower cervical bony anatomy, C3 through the T1 all appear somewhat more similar to one another, where we can see more of a classic body structure with the superior articular facets, the transverse foramen again for the vertebral arteries, and then the vertebral foramen for the spinal cord. The cervical vertebrae, of course, have bifid spinous processes all the way down to C7. Um, C7 also occasionally can have an accessory rib, though it's almost always unilateral. These are just sort of small asides, and I don't think add a tremendous amount of value clinically to any any pathology. But I think it's relevant to mention these things about the cervical anatomy. Um, One thing that I think we actually, can you go on one slide actually? Ken, I just want to see if this is in the next slide or if we should go back one. Let's go back one slide then. One thing that I would like to just point out is this, the foramen between the two vertebral bodies. So if we were going to look at the C2 foramen, this is where the nerve root would exit. And this foramen is created by the articulation between both C1 and C2, or between each vertebral, or between each vertebrae. Looking a little bit more closely, if we go up to the top right image, we can see there on the right side of the image, there's a small space between the C1 and C2, right where Ken has his cursor right now. And that's going to be the foramen through which the C2 nerve roots would exit. But this pattern is repeated all the way down. And so this foramen is what I would almost call a potential foramen, because its creation is through the articulation of the vertebrae as they stack one on top of the other. That's what I wanted to say about that, Ken. Did I drive that home enough, or do you want to say it again in other words?
No, it's good. Just to mention here that C1 is in charge of, yes, extension and flexion. C2, C1 on C2 is in charge of no, so rotation. So
Okay, good.
good here.
Yep, that's fine.
Well, I just want to point out here, this is
Sure.
the uncinate process here, and that makes an articulation with the vertebral body above, and it's only so from C3 to C6.
Good point. Here we have a, excuse me, a little bit of a zoomed out view of the brachial plexus, as well as the nerve roots as they exit through the superior aspect of the cervical spine. I have this in essentially just to show the complexity of it. We're not going to really belabor this slide for very long, but we will talk about the brachial plexus in more detail from a clinical standpoint, so as to help everybody with their physical exams of this. Okay. So I think this is just a review, essentially, of what I was talking about in the first slide, talking about the C1 and C2 stability and the unit that the skull C1 and C2 create, along with the transverse ligament holding, again, the dens or odontoid process in place along the C1 body. Couple of things just to keep in mind is the anterior and posterior columns are supported by the anterior and posterior longitudinal ligaments. These are the ligaments that run along the vertebral bodies themselves. And I think we have an image of it on the next slide, but I would say that these are of lower value. Again, here we're just looking again at the transverse ligament as it crosses over the odontoid process on the left. We're looking kind of from posteriorly, anteriorly to the C1, C2 junction, and we can see the vertebral arteries coursing through the transverse foramen and connecting to form the basilar artery.